The patient that I chose to do my project on was a patient who needed a gastric sleeve surgery, also called a sleeve gastrectomy. A sleeve gastrectomy is when a surgeon removes part of your stomach and joins the remaining portions together to make a new banana-sized stomach or sleeve. This leaves you with only 1/10 the size of the original stomach. The purpose is forced appetite reduction, which helps with weight loss. It also removes the part of the stomach that makes a hormone that boosts your appetite. My patient was a 34-year-old African American female that I'm going to call Elsie. She weighs 265 pounds and is 5'2". Her BMI is 48, and she is considered morbidly obese. She has other comorbidities, which includes hypertension. She's a smoker with a 20-pack year history, a history of depression and anxiety. She has coronary artery disease, shortness of breath, chest pain, and sleep apnea. And this is a photo of what they do in the sleeve gastrectomy. According to Maggard, 16.9% of all adults are considered obese. Reasons include diet, exercise habits, and living environments. Based on the findings of my research, the evidence supports the following. After a gastric sleeve surgery, you want to provide post-op care. This includes hemodynamic support, such as blood pressure, O2 saturations, and heart rate. You also want to monitor their respiratory rates. You want it to fall within normal limits of 12 to 20, and you want to make sure that their airway is maintained. You want to monitor the skin and the wound, and you monitor the lap sites. This is a photo of a person post-sleeve gastrectomy. You want to also monitor their pain management. You want to pre-medicate before any type of activity. And you want to promote activity and ambulations by being up in the chair or walking the halls as tolerated. Early post-op complications to monitor for include a DVT or a PE, bleeding, anastomotic leaks, and cardiovascular or pulmonary compromise. When you're monitoring the wound, you want to assess for bleeding. You don't want there to be excess drainage, and you want to make sure that the drain is stabilized. And you want to make sure that the dressing is still intact. For the diet modification, you want to reiterate to the patient that they need to reduce their portion sizes. They need to pace their meals. They need to chew well and possibly keep a food journal. There's an emphasis on this being a lifestyle change, not just a temporary diet. To help with these big changes, being involved with a support group and working with a dietitian can be helpful. As far as pharmacotherapy, you want to make sure that their pain is controlled. You also want to make sure that they have stool softeners because we don't want there to be any straining. And lastly, you want to make sure that they have an antiemetic such as Zofran or Phenergan because we don't want them to vomit. Some labs that we would monitor would be the creatinine. We don't want it to be above 5,000. That peaks 48 to 72 hours after surgery because that is a confirming indication of rhabdomyolysis. An early diagnosis can prevent further complications such as oliguric acute renal failure. Interventions to prevent rhabdomyolysis include frequent body position changes, both during and after surgery, padding of gluteal and other pressure areas, limiting surgery time, and aggressive fluid replacement. You want to monitor for vomiting and diarrhea. It may just be a short term as patients adjust to the new anatomy. Postprandial diarrhea is suggestive of dumping syndrome. You want to monitor for dumping syndrome. Dumping syndrome is a result of rapid gastric emptying that allows large volumes of hyperosmolar chyme into the small bowel. Signs and symptoms of dumping syndrome include nausea, fullness, and pain. You also want to have a CBC, and you want to monitor the H&H to make sure that the patient is not bleeding. For the plan of care, I wanted to focus on the assessment first. This is how I took care of Elsie during my shift. I monitored vital signs. Her blood pressure was 154/92. This is expected because she has hypertension. I administered her scheduled antihypertensive, and her blood pressure came down to 135/88. Her respirations were 16, which is normal. I did a head-to-toe assessment. She had diminished lung sounds in the bases. This was expected because she was in surgery. She had hypoactive bowel signs. This is also expected because she had abdominal surgery. Her heart sounds were normal sinus rhythm. Her pain level was a 7. I administered her PRN Percocet, and it helped her reposition in the bed. I also gave her a stool softener and educated her about the incentive spirometer. For her diet, I educated and reinforced teaching about the bariatric clear liquid diet. I provided her a medicine cup full of ice chips and instructed her she must wait 20 minutes after consuming until she was allowed more. She couldn't have any carbonation or straws, and her juices had to be diluted. For the goals, interventions, and outcomes, my first shift goal was early ambulation. Elsie needed to be up in the chair for dinner, and I instructed her to call out before getting up because she was a ×1 assist with bathroom privileges. The second goal was to provide nutrition. I wanted her to be able to tolerate her post-op diet with her medicine cup full of liquid or ice chips at a time, and she had to wait 20 minutes in between as tolerated. The third goal was adequate pain control. You want to administer scheduled PRN pain medications according to the physician's order and hospital policy. I assessed her pain on the numbers scale, also every shift as needed, and follow up after 1 hour if given the med. For my nursing care algorithm, first I have a chart of abnormal vitals. This would be a temperature above 100 or below 97, a blood pressure above 160/90 or below 100/60, a heart rate of above 100 or below 60, an O2 stat of below 90%. If this happens, you want to place O2 and call the physician, and a respiratory rate above 20 or below 12. So when the gastric sleeve patient comes back to the recovery floor, you want to check their vitals and respirations. If it's unstable, you would call the physician. If they're stable, you want to assess if the patient is awake. If the patient is not awake, we're just going to continue to monitor. If the patient is awake, we're going to educate about bariatric clear liquid diet. After that, we're going to assess if the patient accepts the teaching. If they do not accept the teaching, we're going to continue to educate at a later time. If they do, we're going to monitor their incision. If it's clean, dry, and intact, we're going to ambulate the night of surgery. That's either within the halls or to the chair. If there's bloody drainage, we're going to call the physician. And this is a list of my references.